Hi folks, I wasn't sure if I was back because I have a slightly blank screen in front of me, but you're all welcome back, and welcome to any new attendees who've joined since we started this morning. Just to remind people that if anybody wishes to pose any questions, there's a Q&A box on your screen if you want to just post a question there, and we can ask our panelists who've kindly agreed to stay on to answer any questions you might have. So the next person I'd like to introduce you to is Judy Ryan. Judy is Director in NMPDU in Kilkenny, HSE South, and she's also the national lead on shaping the future of intellectual disability nursing in Ireland. And I've been working with Judy on the committee now for the last couple of years as the INMO representative, and I can say very much for Judy that she's a very passionate RNID, and I think we're making great strides. So I'll hand you over now to Judy. Thank you, Judy.
Thank you, Eilish. I'm just going to share my presentation with you now, if you just bear with me. You can see my screen now, I hope. Eilish, you might let me know so I know I'm right.
Yes, perfect, yeah. Judy.
Great. Good morning. Like Eilish says, my name is Judy Ryan. I'm really delighted to be speaking to you this morning. A great opportunity to let you know what's happening in relation to the strategy shaping the future. And for those of you who don't know what shaping the future is, it's a strategy for the future direction of nursing and intellectual disability, and it really provides a blueprint to direct nursing intellectual disability into the future. So just my presentation aims is just to give a kind of a reminder of what shaping the future is, its layout, its structure, and then provide an update on the recommendations within the report. And I'm leading out, as Eilish would have said, on the implementation of the recommendations within the report. The information I present today is on behalf of a wider group of very committed colleagues who have agreed to work with me on implementing the recommendations of the report. So it's not just all my own work I'm presenting on behalf of the group, and I'm delighted to be doing so. So just to give a kind of a context to why the need for the report, we know that demographic changes amongst people with an intellectual disability have resulted in the presentation of increased complex health and social care support requirements at different life stages and across the life course for people with an intellectual disability. We know children are surviving, the survival rates for children with complex needs has improved. Adults are spending years in the community accessing work, leisure and community resources, and we have our ageing population, which is a great news story. And just to give a context to the ageing population, we know in 1974, just 28% of the population were over 35. So in 2017, this had risen to 50%. So we know that half our population of people with an intellectual disability are over the age of 35. So really a changing context for intellectual disability nursing. So in addition to that, we've recent policy documents, some identified there at the bottom of the screen, which all aim to provide more individualised support to individuals in smaller settings, enabling greater levels of autonomy for people with an intellectual disability. So in recognising this right to self-determination and positive lifestyle, and it's across the life course, people with an intellectual disability and their families will need to access the skills of RNIDs at various stages and in various settings and in many different ways, from direct care to advocacy to integration across their life course. So this report, Shaping the Future, it represents a significant examination of the role of the registered nurse in intellectual disability in Ireland. And for many of you might have been involved in the consultation process. There was an extensive consultative process and also an extensive literature review to inform the report. So it's a very clear, comprehensive direction that focuses on person-centred, sustainable nursing in intellectual disability. So opportunities again, looking at from cradle to grave and everything in between, and nurses interface with people with intellectual disabilities at all stages of that life course. So in working on the implementation of the recommendations and as RNIDs in practice, we can achieve even higher levels of excellence in the delivery of intellectual disability into the future. And it really is great to have a blueprint to bring us into the future. So the report itself resulted in a framework that has a person, of course, at the centre, within a person-centred context, and looking at nursing, professional leadership in intellectual disability nursing, and the holistic supports of people with an ID across a primary, secondary and tertiary care settings. So we have our framework to guide our current and future practice. So the recommendations within the report are themed into four distinct themes. Person-centeredness, that is threaded throughout all of the recommendations within the report and every aspect of the report. The second theme looks at supporting people with their health, well-being and social care. And this is very important to the overall context of intellectual disability nursing. We provide holistic care across both health and well-being within a social context. So it's neither a social model or a medical model. It's looking at the whole needs of somebody and supporting them in whatever way we can across those needs. The third theme is developing capacity and capability and professional leadership, and we see plenty of that, lots of examples around COVID, and providing experience and outcomes for individuals, improving experience and outcomes for people with an intellectual disability, so that the ultimate aim is obviously that we support people to live to their maximum capacity. Within the framework of the report, and in order to start addressing the recommendations of the report, there were 32 recommendations within the report, and the last recommendation recommended the development of a structure around the implementation of the recommendations. So in doing so, a steering group was established to oversee the work of the working groups within the report. So this representative steering group is chaired by Dr. Jordan Shaw, and she's the director of the Office of the Nursing Midwifery Services Directorate. And it's co-chaired by Mary Kyo Sullivan, who's a National Disability Specialist with the National Disability Office Quality Improvement. And this co-chair arrangement was hugely important in the context of the report, because as you're aware, we work across both nursing and disability services. So we work very much in collaboration with the National Disability Office on the implementation of the recommendations. And there are 3 subject matter groups then were identified when we looked at the recommendations within the report. The main recommendations fitted into 3 subgroups: one on professional development, a second on education, and a third on professional supervision. And I'll speak a bit to these later on in the presentation. So with the professional development, I chair that group of very committed professionals. Dr. Sinead Foran is a group lead for the education subgroup, and Sinead is based in Waterford, in Waterford Institute of Technology. And then Mary B. Rice is an NMPD officer based in the HSE West, and Mary B. is our lead on professional supervision. I have to say at this stage that we also have a sub group addressing the needs of children, to make sure that there's a focus within the work of the groups. Membership of both the steering committee and the representative groups involve participants from the HSE, from education. All of the HEIs are that's the universities and institutes of technology are represented. The Centres for Nurse and Midwifery Education, the representative bodies, HR, the Federation of Voluntary Bodies, the Associate of Nurse Managers, and Workforce Planning. So a wide variety of experienced people, all very committed, I would have to say, to advancing nursing in intellectual disability. So in order to advance the advance the work of the group, when we looked at the professional development and the work of the professional development group, advanced practice, as you know, features widely within the report, and that is really enabling nurses to work to a higher level of practice as autonomous educated practitioners. So the initial priority for the professional development group was to develop a framework for specialist and advanced liaison practice roles. And this is following on from the Department of Health's policy on the development of graduate and advanced practice in nursing and midwifery practice. And when we started out on this piece of work, the reason we went to develop a position paper on advanced practice was that we needed to look at advanced practice in a holistic sense, that the development of the roles would enable access for all, because shaping the future of intellectual disability doesn't have borders or boundaries, so it's not service dependent, it would be access for all. So that was our core focus, and continues to be our core focus, that whatever structures we develop within the under the guise of this work will be equity of access will be core to that. Based on population health needs, work began on the position paper, and I worked very closely with a colleague, Dr. Mary Doolan, on this piece of work. It's hugely important for nurses to be using an evidence base to support and underpin their decision making in practice. And really increasingly very important in health and social care services for RNIDs to actually be coming with reliable data when you're looking for, we were particularly looking for a piece of money from the Department of Health in order to develop advanced practice roles. So the position paper was developed. We went to the Department of Health in December of 2010 and presented our initial position paper. We were advised to revise the position paper and make it return with a more focused paper based on population needs. So we used hospital data. If we went to the HYPE data, which is data that's collated for discharges from hospitals. So it gives you the number of people that are admitted to hospital, the reason for admission, the average length of stay, their discharge dates, etc. So Mary Doolan and myself would have conducted some training on a NICWIS clinical system, which enables us to extrapolate this data so we could use it within the report. Part of the challenge in intellectual disability, all the data within NICWIS clinical is coded. So, and based on primary and secondary diagnosis. So the primary diagnosis might be pneumonia, but the secondary diagnosis may be Down syndrome, that somebody may have Down syndrome. So we wanted to understand or unpick what was in the report relating to intellectual disability. This proved a bit more challenging than we had initially thought. So we did an initial scoping on children and adults with autism and Down syndrome, because they were two recognizable types of causes of intellectual disability that would emerge in the data. So we looked at children from 0 to 16 and adults over 40, and looked at a period of time from December 28 to December 2019, and the number of admissions that where either Down syndrome or autism were identified within the data, the hospital data nationally. So just to give you an example of the value of data and what was included in the report, we know that children with Down syndrome, the predominant reason for admission for that period of time was respiratory illness and cardiac disease. Children with autism, 40% were admitted for autism as a primary diagnosis, and the second was digestive conditions. With the adults, so this again, people over the age of 40, it was for adults with Down syndrome, it was respiratory, 50% of admissions for adults with Down syndrome are respiratory, and the second most common was neurological. And that's probably not a surprise if we consider dementia and maybe some of the problems that come with dysphagia and the difficulties with that for older adults with dementia and Down syndrome. Adults with autism, it was neurological and dental. So again, for us, and for me as an RNID, and in speaking to you as colleagues, what's really important is that we're using this data in order to inform our practices moving forward, in order to inform our evidence base for what we're trying to achieve. So the position paper was presented to the Department of Health in January of the end of January 2020, and then, as you know, the pandemic hit. Just to say, at this stage, although we had to pause our work on shaping the future, the working groups for shaping the future stayed together and worked through the pandemic on different issues relating to the pandemic. So we have gone back to the Department of Health, who have advised us that we now need to get it into an estimates process. So in order to get it into an estimates process, we need to have it in as a business case, which that work is currently underway. And we need to have it recognised within the estimates process within disability nationally. So while this work may seem slow, it's complex in some areas. We're also now working with the National Pricing Office within the HSE, and they price the costing. They provide costings around the cost of care, which we will include in the report. Our ultimate aim with this piece is that we will do a full report based on types of disability, intellectual disability. We've had a meeting last week with the National Pricing Office where we presented 34 common types or causes of intellectual disability, and we will go back into the HYPE or the NICWIS clinical data to try and get a greater picture. Because the ultimate aim, as well as developing advanced practice and liaison roles, is to make this information available to you. So we will complete a full report on the figures and numbers for a defined period of time, and it would be this type of data is available. I would encourage you as advanced practitioners, as CNSs, as nurses in practice, to look at this data along with our National Intellectual Disability Database and our IDS tilde data. So we have great data nationally that we can use, but for the learning as going through this process was, again, that we won't get anything, and we certainly won't get any money without this type of evidence base or data. So again, this data will be used for, if we're looking for liaison posts in acute services, we're now going with an evidence base, say, you know, even if we look at just autism and Down syndrome, for those two cohorts in one defined period of time, there were over 3,000 admissions to acute services. So again, that's going with an evidence base. Separate to this piece of work, would like to congratulate 3 separate areas, as Ailish has mentioned earlier, who were successful in a very competitive process for advanced practice roles. So there are 3 candidate advanced practitioners just commencing post. One is in the Northeast, and it's autism and intellectual disability. There's a second in the National Dementia Service based out of Tala University Hospital, and the third is chronic health conditions in the Southeast. So that's 3 additional posts in conjunction with the existing posts. So the number of posts will increase over the coming period of time, and I'm really looking forward to that. The second group is an education subgroup, and the education subgroup, again, chaired by Sinead Foran, and it is, it has educationalists from the universities, the HEIs, and from nursing, our Centres for Nursing and Midwifery Education. So, and in line with the recommendations, the group are currently addressing current and future undergraduate placements. They've developed a template database to collate information on the current undergraduate placements and what the future undergraduate placements need to look like in order for nurses in intellectual disability, the future graduates, to be experienced in all aspects. So they need to be where people with an intellectual disability are. And it's not the same as it would have been in the past, where they were in a service and everything, their wraparound service was provided by that service. People are in their community now, so enabling nurses involved in the undergraduate programme to avail of wider scope and wider experience is hugely important. And we look forward to being able to share that information and develop those posts in line with the requirements and standards. Work is also underway collating, and we've just about finalising it at the moment, on education programmes that are available at undergraduate, and postgraduate level, both in the universities and the Centres for Nurse Education. And I have to say there are a huge number of programmes available. What has been of interest is the need for nurses in intellectual disability to widen the scope of attendance at programmes outside of the programme specifically related to intellectual disability. If we look at the earlier slide across the life course, we know that people with an intellectual disability have babies, they access mental health services, they access acute services, they're in primary care. So they're in lots of places, and they have lots of health and social care needs. So I would encourage you to look at the wider programs and try and access as many of those as you can. And we're also, which we will obviously of course be sharing the learning, and we have commenced work on the promoting intellectual disability nursing. Sinead Foran, as the chair, met with the chair of the National Career Guidance Teacher Network, and to determine how nursing is promoted within the careers fairs and as a career within schools. And we know that there's a lot of work to be done on that. We're advised that people are guided towards social care as opposed to nursing. So as nurses in intellectual disability, there's a lot of promotional work that has to be done there. So that education subcommittee have looked for an extension of the time period for work, because obviously all of our work was delayed with COVID. The third working group is professional supervision, and there's professional supervision and clinical supervision, and it takes many different forms and guises within services. So a recommendation of the report was to have a national structure for nursing and intellectual disability, and Mary B. Rice, who's an NMPD officer in the HSE West, is leading out on the professional supervision piece, and that's looking at having a national policy structure similar to that's available for mental health nursing in professional supervision. Additional work that the groups are involved in is enhancing the presence of the clinical nurse specialist database and other work around clinical nurse specialists posts maintained by the Office of the Nursing and Midwifery Services Directors. We know in the past that the National Council held this database, and that database is currently being a data cleansing process is currently underway with the Office of the Nursing and Midwifery Services, because lots of the CNSs who may be on it may have retired, they may have gone into management posts. And Emma Fleming is our link person, and Emma works in the NMPDU in the Northeast, leading out on that piece of work. And it also gives us a baseline understanding of what's currently out there and what might be needed in the future. The working group, as I said earlier, worked throughout the COVID period providing guidance and support, and this is recognised, and we have been asked to revisit some of the supports that were offered throughout COVID. Again, as the numbers are starting to emerge, and we're working with the disability services nationally to advance these pieces of work. We've also fed in through the group on the National Children's Strategy, and I'd be delighted to hear Rosemary. We've collaborated with Rosemary Sheehan, who you'll be hearing speaking later on, and we've also worked to influence the revision of the National Policy on Expected Deaths that was being revised through COVID. We did a small piece on the Year of the Nurse. Obviously, everybody had bigger plans. We just did a short video clip to promote the Year of the Nurse. Everybody had we all had greater plans for that, but we had to modify them. But we have, as you know, we had our initial conference last year. We had our second conference planned for October, but of course, like everybody else, we're troubled by COVID. So we have planned a series of 3 webinars. There will be 2 in November and 1 in December, culminating in the Day of Disabilities, the International Day of Disabilities. And details of those will be finalised within the coming days, and we will be sharing that information out with you. So just to conclude, really, this is really just a snapshot of a background, a revision of what the report has identified. And just to give you a very quick snapshot of the work that's ongoing, there's a lot of gathering of information in order to have a baseline, in order to move forward or to plan or to look for supports. We have to know what we have. So in every piece of information that we collect, there's a value to that. And just to say that you have a very committed support team working on the Shaping the Future and implementing its recommendations. Everybody's doing it in addition to their current work, and we're working as hard and as fast as we can. We're representing intellectual disability nursing at every opportunity we can, and using every forum to work with people, and we will continue to do that on your behalf. If there's any questions or queries, you can always contact the office here, and I'll be happy to answer your queries or to help in any way we can. So thank you for your time. I'll hand back to Ailish.
Thank you, Judy, for that comprehensive whistle-stop view of what's going on with Shaping the Future. And to be fair, I think sometimes when you're looking from the inside out, you perceive things to be very slow. And from where I'm sitting and having spent the last number of years involved behind the scenes, I suppose, I think things are moving nicely along. We have a lot more CNS roles developing, liaison roles. We now have 3 new A&P posts. So I think that's huge success, and onwards and upwards. I just have one question that came in, Judy, around the nurses who work in intellectual disability who are not intellectually disability trained, they're not RNIDs. Is there any update on a postgrad for nursing in ID, I suppose?
Yeah, I know that request has gone into the Department of Health, and I know the department were reviewing it, and the last piece of advice we had from the department was that they needed the follow-up request to come in from services looking for it. So there's a piece of work to be done to push that forward or drive it forward.
Lovely, that's great. And I think one of the main points that you made throughout your piece was that the data is so important, and I think if we could get one big message out there today, it's that every nurse in ID needs to start looking at research and, as you say, taking on courses. And if we can I suppose map our way in evidence, we'll get to the end of the road. That's lovely. Thank you very much, Judy.
Thanks, Ailish.
So we'll move on now to our next speaker, Jonathan Drennan. Jonathan has a long history in research in many areas in nursing, and one of his disciplines years ago, if he doesn't mind me saying, was intellectual disability. He's currently the chair of the Nursing and Health Services Research at UCC, and was the man behind, I suppose, safe staffing in the acute sector. So we're hoping that he'll be able to shed some light on how that can be transferred into intellectual disability. Thank you, Jonathan.
Thanks, Ailish. Good morning, everybody, or good afternoon, and thank you very much for the invite to the RNID conference. Just going to start sharing my screen here, so everybody should see it now in a second, hopefully. Hopefully you can see that. So the work I'm going to talk about today is really the work that we've been doing through the Health Research Board and the Department of Health funding, which has been looking at safe staffing, mainly in the acute sector. So we developed a framework for safe staffing in medical and surgical settings, and we have just finished a large program of work on emergency departments, and that report has now been submitted to the Department of Health in the last couple of weeks, and we will develop a framework for safe staffing in emergency settings based on that work. We've identified a model to do that. Just to acknowledge the team, the research is led by UCC, but our colleagues in NUIG, Professor Anne Scott, who many of you will know from her work on the RN forecast. I previously worked in the University of Southampton, and there's a large nursing workforce research team there, and Peter Griffiths and Jane Ball, and then Australian colleague, Professor Christine Duffield. The previously we were talking about Ailish and Judy were rightly talking about data, and data has driven this research, and data is what's really driving us to make the changes. And when we talk to policymakers and we talk to key stakeholders in the Department of Health and the HSE, the decisions are based on data, and getting good quality, strong data has been essential during this process. It's not easy to do. It's certainly not an easy thing to do, but there are processes to do it. Just to give an idea of where we are in Ireland and looking at the workforce in Ireland and the health workforce. So the health and social care workforce in Ireland, these are the latest figures that we have in relation to this. So about 11.9% of the total workforce in Ireland is working in health and social care. And you can see, as in most of the OECD 36 countries, that has increased. But we've come a long way in about 17 years, but there's still further to go. We had a relatively low baseline, whereas around 6 to 7% of the total workforce are working in health and social care, but that's increased to 11.9%, which is above the OECD average of 10.1, but would be lower than some comparable countries such as Norway, Denmark, Finland, Netherlands, and so on, where a number of countries have invested in their workforce over a number of years. If we look at the nursing workforce in Ireland, there is an interesting picture. So, and again, there's a lot of debate about where these figures come from, how accurate they are, and so on. And I would always say that with data at this scale, we need to treat it with caution, but it does give us a fairly good snapshot of where Ireland is. So if we look at the OECD, the developed countries in the world, the OECD 36, there's about 8.8 nurses per 1,000 population. And that goes from a low in some countries such as Turkey to up to 17 in Norway, Switzerland, so on. What you do see in most countries is that nurses per capita or nurses per population are growing. And the reason they're growing are twofold. One is population growth. As your population grows, you need more nurses to care for the growing population. But the second one is that as the population ages, and earlier on, Judy was talking about the growth in the proportion of those that are aged over 65. So our intellectual disability, people with an intellectual ability cohort is also aging in line with the general population, and the needs of that population are extremely important. Ireland hasn't really grown over the period of 17 years. We've actually dropped in the proportion of nurses that we have per head of population. We did have 13.9 in around about 2008, about 13.6 per thousand population. It's dropped to 12.2. So we're not really keeping pace with our population changes. The other thing about the Irish figures we have to take into consideration when we're comparing to other countries, Ireland includes midwives in these figures, other countries don't. Ireland tends to include everybody who has a nursing qualification, so people working in management, people working in education, and so on, whereas other countries the majority of other countries tend to include just clinical nurses. So we would have maybe a slight overestimation. The other thing is we tend to just include RNs or RMs. Other countries sometimes include nursing associates, not healthcare assistants, but nursing associates and so on. So these figures give us a snapshot, but we need to treat them with some level of caution. And you can see the Ireland is here, this figure here with the red arrow. You can see whether other countries have gone from 2000 up to 2017. Ireland hasn't changed that much. If we look at nursing graduates, the graduates that we produce, Ireland produces less nursing graduates than the OECD average. Many countries, Switzerland, Korea, Australia, Norway, and so on, have invested heavily in its graduate nurse population with the view preparing a workforce that is going to be able to deal with the challenges of an aging population and people with more complex health problems. Ireland has remained relatively steady around 28.9 nurses per 100,000 population. I know due to COVID-19 and the Leaving Cert, there were some increases around about 5% this year was to be welcomed, but as mentioned earlier, we need to look at new models for nursing graduates in the future as well. A sort of better picture gives us the number of nurses that are working in hospitals and full-time equivalents. And I'm going to talk a little bit about the impact of the recessionary years on healthcare in general, and then we can look at the challenges for learning disability in particular. So between 2006 and 2016, when we look at headcount and full-time equivalent, the headcount and the full-time equivalent in Ireland for nursing actually dropped over that period of time. And this was mainly due to the recessionary years. So per 1,000 population, we went from a headcount of around 6 per 1,000, and that dropped down to around 5 per 1,000 by 2016. There has been some recovery since then, but certainly not to the extent of what happened before the recession. The other challenges that we have in the Irish Health Service, and these are very well flagged. You can see Ireland has one of the fewest beds in the OECD. We're well below the OECD average there of 4.7. We take 3 beds per 1,000 population, and that puts pressure on systems. And we know people, as they develop complex, as they grow older, will need inpatient care. And we can see that there has been a drop there. And the other area where we lead in Ireland is that we have the highest bed occupancy rates in the world. We have a bed occupancy rate of 9.9%, which is way below the OECD average of 75%. And it's recommended that bed occupancy rates generally for safe and effective care shouldn't really go above 85%. But this is an issue that government and Department of Health and HSE are aware of, but bed occupancy rates are relatively high. This leads to lower lengths of stay, it leads to high levels of turnover, and it can lead to crowding in emergency departments, which we see. So really, we are slightly living with the legacy of the austerity years between 2008 and 2014. And this is from a paper published by Williams and Thomas. So we had a 7.2% reduction in the health service workforce, and this was an interesting reduction, and we'll break down how those reductions were. I know since my time working in the area of intellectual disability many years ago now, but training in St. Raphael's and Selridge, there was a big push at that time in relation to developing community services. I would have worked in a very large residential sector, but they were planning for the development of community services, and this would have needed more and more of the health workforce to move into community settings. But during the austerity years, we lost more staff in the non-acute sector than in the acute sector. So basically the pay bill, due to cuts and early retirements and so on, and reduced the pay bill by 11%, which was needed. And there was a voluntary early retirement scheme. So basically 1,600 in management administrative support exited from the front line. But the knock-on effect of this was that there was, even though the pay bill reduced by 11%, because units and wards and so on needed to be safely staffed, there was an increase in agency use during this time, and there was a real saving of only 3.4%. And I think we've all learned lessons from this. You cut staff, but then what happens? Do you actually make the savings that you're planning to make? And you really don't. So basically the overall savings to the health service during the austerity years were much reduced. So we had nearly a 270 million euro increase in agency spend, and that ballooned by 320% during the agency years. So one of the reasons behind the task force for safe staffing is to reduce really the use of agency nurses, because it is phenomenally expensive. And then there are other issues with agency nurses in relation to continuity of care and so on. Agency is a very, very important process, but an over dependence on agency can be detrimental. So if we look at where those losses of staff were, and I know that's a little bit difficult to see, there were certain groups such as therapists, nurse specialists and non-consultant hospital doctors and consultants that actually went up in the recessionary years, but nurse management reduced by 10.4%, and staff nurses staff nurses at the front line, we had a loss of 10.7%, and we are starting to show some levels of recovery from that. But we can see that those levels of staffing were reduced in this particular area. So the overall consequence of the changes during the austerity year, there was a flip. Whereas there'd been an emphasis on non-acute care and community care, where we had 54,000 healthcare staff working in that area in 2008 and 52,000 in the acute sector. By the end of the recession, as we were coming out of recession, that had flipped. We had dropped to 47,000 working in the community sector, and we'd dropped to 49,000 in the acute sector, but we had more nurses now working in acute than a non-acute. So this is from this lesson is that cutting your health services during a recession in effect can have a detrimental effect on many issues in relation to budgetary control, in relation to loss of knowledge, and to the type of services that are provided to people who need those services at that particular point. So if we look at where we're going, and this is where we really need to use data to plan for the future. So the projections in Ireland from 2016 to 2031, and this is from the CSO projections, and 2021 is not that far away, it's only 11 years away, we'll have a 12% growth in our overall population in Ireland. So to match that growth in population, we will need a growth in the healthcare workforce, and in particularly the nursing workforce. As you can see, we've slightly fallen behind according to the OECD. There will be a 59% growth in the 65 years of age and older population, and that will be certainly seen in the population of people with an intellectual disability, and we will have a 95% growth in the 85 plus population. This is the population, the 85 plus, that we're not saying growing old is a challenge, but the demand for healthcare increases as you go older. So we look at the moment, approximately 20% of all people aged 85 years of age and older are in some form of residential care. So your proportion of people within residential rises as you get older. So if we look at that cohort of people aged over 65 and what we need, they account for approximately 13% of the population at the moment. So we're relatively young in European terms, but they require approximately 1/3 of healthcare activity. So 13% of the population takes up 33% of healthcare activity. And that's important activity around that. In 11 years' time, the population aged over 65 will be around 19%, but it will account for 50% of all healthcare activity. So this needs a huge change in the way we think about nursing our older population and the provision of care for our nursing population, both in general, both in learning disability, mental health, and so on. So by 2031, we will need a 48%. This is from the Department of Health themselves, the Health Service Capacity Review, which was published in 2018, we'll need a 48% increase in our primary care workforce. As I mentioned earlier, as you grow older, you require more residential and long-term care. So this will have to increase by 43%. And to keep people in their homes as much as possible, we need a 120% increase in home care. Looking at the community again, GP appointments will go from 18.9 million to 26.2 million. GP practice nurses will become important. There will be an increase there, and we need an increase in public health nurses. There'll be an increase in public health nurses by 46%. So where are all these health workers going to come from? This is the challenge. So at the moment, when we look across the OECD, the most developed economies within the world, there's approximately 4 people of working age. That's the OECD classifies that as between 15 and 64. But in Ireland, working age is probably is older for every person of 65 years in 2012. So that's not 4 healthcare workers, that's just 4 people within. But in the next 40 years, this is projected to halve. So there'll only be 2.1 on average people for every person over 65 in the next 40 years. So that has challenges for the recruitment and the retention of the healthcare workforce. So as Judy and Ailish mentioned, we really need data, and the excellent report from the HRB, the annual report on National Intellectual Disability Database Committee, gives us a really, really good picture of what's going on. And I won't go over them too much, and I know Judy identified them, but we can see where there are peak costs in people aged over 65. As we said, Ireland is pretty young, but these trends and patterns tell us. So in the 2016-2017 census, we had just over 6,500, representing 1.4% of the population. It's a pretty large proportion are recorded with an intellectual disability. And this has gone up. This has gone up by 15.4% from 2011 figures. And we know there are more males and females within this cohort. So this is going to have challenges around it. And we know that the proportion of older people with an intellectual disability or over age 65 is also rising. You can see the trend graph there, it's going up. The disability shows us again, as I mentioned, that life expectancy has improved, which is great to see. When I started in learning disability in the 1980s, the early 1980s, life expectancy was much, much lower than it is today. This has implications, though, for service planning, and there will be an increased demand for full-time residential as well as community settings over the years. And we can see that when we look at the services required, there will be over nearly 5,000 new residential day and support places needed, and an increase in day programs and an increase in day support services. The report shows us as well there will be an increase in the nursing related required. At the moment, the majority are around 8,382 are receiving the service, but the HRB report identifies that there are nearly 3,000 who require an enhancement of intellectual disability nursing services. And there's around just under 1,800, just under 900 are not receiving this service and will need to receive it. So there are challenges there for those who are not receiving a full service and those who do, who require access to the service over the next 2 to 3 years. The excellent Shaping the Future of Intellectual Disability Nursing in Ireland, this is a report that was long needed, identified that intellectual disability is the key profession in the provision of health and social care supports for people with intellectual disability. And I think this is where intellectual disability differs from other disciplines, is that it's got its health and social aspect of care, which is very central, but that has challenges in relation to determining the intellectual disability workforce in the future because of the complexities around that. The report recommended that in the context of integrated workforce planning, a national staffing framework will be developed based on the best international evidence. And this will require senior nurses, planners, and managers to examine the deployment of and the skill mix to ensure that services are matching clients' needs and residents' needs and people with a learning disability living in the community and so on. The issue is that when we look at intellectual disability nursing and we're planning for the workforce, and this is from Shaping the Future report, you can see the complexity that it goes from through the lifespan, from pregnancy right through to end-of-life care. And as I'll show you some of the evidence that comes out from intellectual disability and nursing in relation to workforce, this is where the complexities lie. The issue is when we look at the association between safe nurse staffing and outcomes in the acute sector in general nursing, we have a lot of evidence. We have a huge amount of evidence. And basically it shows that when you have a reduction in the nursing workforce, you get an increase in levels of mortality. And there's a number of studies that have shown this. And you also get an increase in adverse events, impact on patients. You get a reduction in staff satisfaction and so on. When we move out of the acute sector into other settings, emergency departments, mental health, learning disability, the evidence is relatively weak. And this is the challenge in the future. So Mafubu et al. In 2014 have, for NHS Improvement, did a evidence review, and they found that there was some evidence on staffing and job satisfaction, the needs of clients, the types of staff, organizational support, teamwork, stress and burnout in staff, and staff perceptions of challenging behavior. They were related, but the report concluded that, and this was carried out by the University of West London for NHS Improvement, that there was no empirical evidence was located that was directly relatable to sustainable safe staffing. So this is the issue that is going to be a challenge in the future for looking at developing models for safe nurse staffing and developing a framework for safe nurse staffing in ID nursing. The report concluded that the conclusions from this review leave a number of questions unanswered, and they also include that the concept of sustainable safe nurse staffing and learning disability services must be clearly understood from the very complex of the models of care. And that goes back to the previous slide where you have intellectual disability nurses working with people from pregnancy right through to the end of life. The extent of the number of professionals, it's a very multidisciplinary team approach of the care of a person with a learning disability, as well as the healthcare agencies involved and the various settings. So there is a lack of robust evidence regarding sustainable safe staffing. I'm not saying that there is not an association between safe staffing and outcomes in learning disability and intellectual disability nursing. There certainly is. We certainly know there would be if we look at other areas, but the evidence is not there, and that requires a body of work to do that. The National Quality Board, which is part of NHS Improvement in the UK, have produced guidelines on an improvement resource for learning disability services. And this is in the key context of reducing health inequalities and increasing the life expectancy of intellectual disability. This is not a bad framework. Again, they acknowledge that evidence is relatively weak in this particular area, certainly not as strong as that comes from the acute settings, but what they look at within the policy document is that by identifying a model for safe nurse staffing, and again, this is the UK, it will reduce attrition of staff, reduce the number of adverse incidents within the care of people with disability, intellectual disability, reduce the use of restraint, reduce assaults on staff, inappropriate hospital admissions, so keeping people in their home or within residential care, reduce costs of the system of inappropriate placement, and most importantly, improve user and carers' experience. Again, there's very little evidence in relation to those. The model goes through right staff, right skills, right place, and right time. I won't go through them in detail, but basically they're saying that workforce planning in intellectual disability must be integral to the healthcare provider's strategy and operational planning process. The issue in Ireland is that for many years we've identified our staffing requirements on legacy issues. We've always had this many staff on this unit or on this ward, even though client need has changed, clients residents, people with intellectual maybe become more dependent, may have complex health problems, but the staffing remains the same. What we are finding now, by introducing the framework or a strategic, systematic approach to determining nurse staffing in acute settings, the staffing resource is meeting patient need rather than being based on legacy issues. How do we identify safe staffing for the future? Professional judgment is the weakest. There are multiplier tools out there. Jeffrey Hurst has developed a tool in learning disability in 2014, 2015. There are caseload weighting tools looking at the caseload analysis on the dependency levels of people with a learning disability. There are outcome monitoring tools. World Health Organization quality of life. Is the quality of life of a person with intellectual disability improving? Is that related to the staffing levels? Context of care tool, which was developed as part of the process of developing these guidelines. And also then there's a Scottish tool, which is called Mental Health and Learning Disabilities Workload Tool. Again, questions about why they brought mental health and learning disabilities together. It is probably the tool, though, that's nearest to the work we do in the framework, because it looks at the day-to-day care that's provided to people with learning disability in various settings, and the workload is based on the care that is delivered by nursing staff within those various settings. So what do we need for the future? An evidence-based model for determining nurse staffing requirements and skill mix. Very much that's been done by the Task Force for Safe Nurse Staffing. Need to take the context of the diversity of settings in which ID nurses work, and we know there are a huge amount of settings in which they work. We need leadership. We need to free nurses up within intellectual disability services to act as leaders within the service. We need accurate data, as Ailish and Judy mentioned, and this is going to be really important. In the acute care settings, we can get mortality data. Mortality data is the most accurate piece of data you can get. And we work on that data. We look at staffing, we look at mortalities in the wards. We look at where staffing is low, mortality goes up. Where staffing meets patient need, mortality goes down. It's as effective as that. But in intellectual disability, mental health, emergency departments, mortality is not the outcome indicator we're interested in. We're interested in other outcome events, and that's where the challenge is. We need to increase the number of nurses with a qualification in intellectual disability nursing. There's no doubt about that. And that's based on the trends that we can see within the data. And we need, as Judy mentioned, the development of specialist grades, CNS and AMP. The Task Force on Staffing and Skill Mix, we've done the acute sector, we've done medical surgical, we've just finished ED. We are moving on to the older persons sector and the community sector next. That's the next plan, and that has been identified in a number of documents. Community is based on the recommendations in Launch Care, and older persons residential settings is based on the expert nursing home review report that was published about 6 weeks ago, and they recommended that the Task Force for Safe Nurse Staffing and Skill Mix look at those areas. We have no plans at the moment to look at intellectual disability, but that's not to say it won't happen down the road. We have published a number of reports. The evidence reviews that we use for those, the framework for safe nurse staffing and medical surgical, our protocol is published as well. And there will be a framework published in the near future for emergency department settings, and then hopefully for older persons, community settings and so on. So what we're trying to do is use a systematic evidence-based approach to determine safe nurse staffing and skill mix within these settings, and certainly looking at the evidence, there is a need for further work in the area of intellectual disability nursing and related outcomes for intellectual disability nursing staffing, and the outcomes related to people with an intellectual disability. Before I finish, we have to acknowledge the HRB, who funds our research. We're very grateful for that, and the Department of Health, who also fund our research. So thank you.
Thank you, Jonathan, for that comprehensive overview of that research. I suppose it's worrying, the worldwide nursing shortage, and indeed in Ireland. And I suppose I'd reiterate that we are very lucky in Ireland to have intellectual disability nursing, because I know it's a rare qualification. But I think it's a very valuable one, and based on the knowledge we now have from the TILDA studies and other research into lifespan and illness and all those things attached to a person with an intellectual disability, I think it's probably more important now than ever. And just on the OECD data, I suppose maybe the INMO don't fully agree with those stats. They're not fully reliable, as you said, with caution. I'd just like to reiterate that, because they're not fully reflective, I suppose, of the frontline workers. And you mentioned there at the end about the older person and the safe staffing. And I think if there's any area we're probably most like, I suppose, is the elderly care. And if the elderly care movement goes in the direction it's going into community-based houses as opposed to maybe nursing homes and that, then we might fit in a little bit better. So I'd be very hopeful that there would be a lateral thinking, I suppose, around safe staffing. There's just a question that came in here, Jonathan. It's what would you consider to be safe staff nurse ratio in a special school with children with moderate to profound learning disabilities? It's probably not an easy question to answer, but just your opinion on that, please.
It's a very good question.
Yeah.
And no, it would be, it's a difficult question to answer, but if you look at creches have set ratios, but when we look at nursing, we don't have set ratios, but there is legislation. So we've no legislative framework for what the staffing level should be in a number of settings. We've based it from a number of years on professional judgment, and that's pretty good. You know, when we go into units and we say to somebody who has an experienced nurse, how many staff do you need to run this unit or this ward or this special school safely? They will know. They will generally know. The issue in relation to that particular question is we would need to go in and look at the outcomes in relation to that. And to a large extent in the area of intellectual disability, we don't have those outcomes yet. So if we were to put changes in, we would look at things like, we look at all this safe staffing research is, in some way, it's terrible because it looks at adverse things. It looks at things that go wrong. It looks at, you know, adverse events that impact on people, you know, the most adverse event in the community. But we look at other things as well, such as falls, such as the use of restraints and so on. So it's very difficult to answer that question without going in and doing some research in that particular area. That would be the issue.
Okay, thank you for that, Jonathan. And thank you for your presentation and participation today. So we're just going to sign off now for a few minutes, just a quick break again, an ad break, just to give everybody a few minutes to refresh, and we'll see you back in about 3 minutes. Thank you.